next section we'll discuss is some basics on deworming. I think more so than the other sections, this is hopefully a section that you guys are well informed. I mean, you should have covered it in parasitology in fairly in-depth kind of nature. I'm then going to just highlight some specifically important things to equids. Maybe it's slightly different to other species. Okay, so the first important thing is basically the idea that several generations to several years ago, there was this idea that we performed an interval deworming. So every horse got a dewormer like every 2 to 3 months. This was specifically designed to control large, strong guards, and it was very effective in controlling large, strong guards. But as time kind of went on, the large, strong guards became less and less of a problem, and we started to have to deal with other pathogenic worms, particularly cyathostomes. Okay. And this practice also then started to lead to this widespread anthelmintic resistance, which I think, you guys will continue to have this hammered into you at exhaustion. Resistance in antibiotics, any of these drugs is really important. So this is a bad strategy, and so it's no longer recommended that you deworm every 8 to 12 weeks. We now have moved towards these selective deworming strategies that we're going to discuss. Okay. Good. Okay. This is basically just an overview of the different dewormers. Okay, so remember there's multiple classes. You have multiple drugs in each of the classes, and they all obviously have similar mechanisms of action. Okay. It's a good idea to have these kind of classes at least in your minds, just so that you can kind of understand a little bit in terms of these deworming programs. Okay. What I'm going to now do is I'm going to discuss specific worms that are important in equines. Okay, so I don't know, you guys should hopefully remember from parasitology, they speak about the 5 colic worms. Okay, those are really important 5 worms in South Africa, and those are what we're going to focus on. Okay, so the first is roundworm. The specific is Parascaris equorum. Okay, so important in weanlings, so 3 to 9 months old. The major site for these worms is going to be the small intestine, and it's really quite interesting that these equids develop an age-related immunity to this Parascaris worm. So it's not something that you see in adults normally, and there are exceptions, but that's why it's really confined to the weanling kind of class. If you're making a diagnosis of this, it's going to be based on fecal egg counts. So McMaster fecal egg counts, you can actually identify this worm specifically. Okay. And then treatment strategies are basically going to depend on individual kind of worm burdens, and it's going to depend on the age of the horse. So you, as I said, shouldn't really be seeing this in adults, but it is something that you're going to see in foals, and you should be focusing deworming for this in foals, initiating deworming with fenbendazole, and avoiding the dewormers that are paralytic in their action. Okay, so fenbendazole is effective. Ivermectin is also really effective for this worm, but it causes paralysis of the worm, and that leads to these so-called asteroid impactions more likely than fenbendazole. Okay, so what you do is you start off your deworming with the fenbendazole to hopefully reduce the worm burden. Okay, and then you're going to implement the ivermectin later on in the deworming process when the number of these Parascaris worms are significantly reduced. Okay, so that's important to kind of take note of. Then I think probably at this stage the most important worm in the adult horse are these small strongyles or cyathostome worms. Okay, their site, predilection site, is the large colon and cecum. And the important aspect of these worms is that it's the larvae that cause the problem. Okay, so you have these larvae, they go and encysst in the colon wall, so they form these little encysted nodules. And when they emerge, they can cause damage to the colon that causes inflammation and swelling. And then this basically leads to colitis, and that's what you're going to see in terms of clinical signs of this, predominantly in bad cases presenting with diarrhea. Okay. Obviously, diagnosing this is quite difficult, so you can do fecal egg counts, and it's going to tell you that you have Strongylid type worms, but remember, only adults produce eggs, okay, and we said that the problem here is the larvae, okay, so the presence of eggs doesn't necessarily mean that you're going to develop disease because of larvae, and the absence of eggs doesn't mean that you're not going to develop disease, okay. So another option is actually finding larvae or these thin little red worms on a rectal sleeve or in feces, but again, it's not a guaranteed diagnosis. We're moving towards doing some serology, so there is an ELISA available for these cyathostomes, so you can take some blood and test on that. But again, although they may indicate that there is presence of these worms, presence doesn't necessarily equal causation. Okay, so you can have a horse with colitis that has a serology positive for cyathostomes, but the cause of the colitis is salmonella, for instance. Okay, so it's quite difficult to actually know, and you'll see that we implement a specific deworming strategy for this. Based on that fact. So in essence, you're deworming once a year with a larvicidal product in all horses, okay, just to make sure that you're covering these larvae, not specifically looking at the diagnosis. So there's several products that are kind of use, but I think the main ones I want you guys to know is moxidectin. So a single dose of moxidectin is going to kill larvae, okay, and adults. And then the other option is 5 consecutive days of fenbendazole. That can also be effective against larvae. Okay, so most of the time we're probably going to be focusing on the moxidectin because it's a little bit easier. It is slightly more expensive though to go that route. Okay. Good. Then we have the large strongyles, which we said that interval deworming was focused at. So we don't often see disease because of these. That interval deworming has almost made this worm kind of like extinct in inverted commas in equine practice. So you don't often see disease because of it, and so it's not really the main focus of deworming, but there are some cases where you may see it in. So again, this worm infects the cecum and normally the ventral large colon. And its pathogenic potential is more related to its migration. So it migrates in the blood vessels of the mesenteric arteries, and it can lead to thrombosis there, and obviously thrombosis will then lead to blood compromise or blood supply to the intestinal tract, leading to colic and problems there. Diagnosis basically based on fecal egg count and susceptible to macrocyclic lactones, benzimidazoles, or pyrantel. Okay, but again, not necessarily the one we're going to focus on with regards to deworming strategies. Okay, tapeworms. The most important one for us is Anoplocephala perfoliata. Okay, so site of predilection is the ileum and the large colon. This can predispose horses to developing ileal impactions or ileocecal intussusceptions, and this is more seen in horses over 6 weeks old. The diagnosis is made in several different ways. You can either basically see tapeworm segments in the horse's feces, but it's important to note that they don't consistently shed these segments or eggs in the feces, so your fecal egg counts and that fecal testing doesn't always guarantee that you'll identify these worms. So again, they're going to recommend in these deworming strategies that you do at least once yearly deworming with something effective against tapeworm, which is praziquantel. Okay, really straightforward and easy. I want you guys just to remember praziquantel for tapeworms. Okay, good. So tapeworms. And then the really important trematode, which is Gastrodiscus aegyptiacus. Again, predilection site cecum and colon. So remember that this has the freshwater snail as the intermediate host. So you can often identify at-risk equids again based on their environment. It's animals that are close to dams, flays, marshy areas, those kind of things, where these freshwater snails can survive. Diagnosis is based on either fecal sedimentation or fecal filtration, and specifically the treatment of choice here is oxyclosamide. Okay. It's just on a side note, you currently do get oxyclosamide individually, but in South Africa we don't at this stage have a registered formulation for deworming for this in equids. So you're going to use this extra-labally. Important to also note that there are oxyclosamide dewormers for cattle, for instance, mostly going to be aimed at liver fluke, that have a drug called levamisole in that. And levamisole has a very low lethal kind of dose for horses. Okay, so it's very important that you are very careful if you're going to use those combined products in horses, that you accurately weigh and dose according to weight. Okay, but as I say, currently there is an individual product that you get that has only oxyclosamide in it, and it's probably preferable to try and get your hands on that specifically. Okay. And then I mentioned liver fluke here, so Fasciola hepatica, with some asterisks, because horses don't easily get liver fluke. Okay, so it's not something that is going to be on the top of your differential lists in any of these scenarios, but some horses can develop it. Okay, so again, in high-risk scenarios, there may be horses developing liver fluke. You're going to be deworming those horses with triclobendazole, but I think that this is something just for kind of your information at this stage. The one I want you guys to remember is Gastrodiscus. Okay, good. Then pinworm, so Oxyurus equi. Is it a colic worm? It's not. Is it a worm that's going to kill your horse? No. What does it do? Well, the female worms, they sit in the rectum, and then they come out and they lay their eggs on the perianal skin, and that gives the horse an itchy butt. And so these horses are going to be horses that you generally see rubbing their bum or their tail. Okay, you'll see horse owners are obsessed about a good-looking tail, and rubbing the tail can obviously damage the hair. It can also cause some like abrasions and that on the horse's tail. So it's kind of to focus on the horse's comfort that you're going to be looking at this. So as I said, tail rubbing and rubbing of the hind quarters, and then perennial skin excoriations are going to be kind of signs that you may see of these worms. And if you're going to diagnose this, you're going to do the Scotch tape test. So remember, you take some sellotape, you basically stick it on the perennial skin, and then you're going to look at that for eggs under the microscope. And I mean, in essence, treating these worms are going to focus with benzimidazole, so one of the benzimidazoles. Okay. Good. And then I mentioned this, the intestinal threadworm, so Strongyloides vesteri. It's quite a controversial worm, so there's differences of opinions on whether it's actually a disease-causing worm or not. Again, this worm is found mostly in the small intestine. It's also mostly focused in folds, and it is uncommon to see disease caused by it, except if you have extremely high worm burdens. So you'll see in large studs that produce lots of foals, this worm can sometimes be a problem. It's also an interesting worm because there's different routes of infection. So you can get an oral ingestion, and you can get a percutaneous invasion of the larvae. But what's also very interesting is that you can have these worms transmitted via milk. Okay, so from lactating mares to foals, and that obviously leads to kind of when we're going to deworm with this. What does this cause? Well, it can cause enteritis, it can cause dermatitis and hyperactive behavior when you have this percutaneous invasion. And generally what we're advocating is deworming mares just prior to foaling, so you reduce the shedding in milk and then hopefully you reduce transmission to the foals. Okay. Again, certainly not the most important of the worms we discussed today, but something to be aware of. Okay. Now we go through some more kind of general concepts. So the goal of deworming here is not to remove all of the worms in the horse. Okay. The goal is to limit the number of worms so that you don't have illness actually developing because of that. Okay, so you want some degree of worm burden so the horse develops its own kind of response, immunity to those worms. Not a good idea to necessarily completely remove worms or eradicate them completely. Okay. So also remember, as we said, the larval stages of the small and large strongulls are the important stages for disease. So basically we have to focus on treating for those, and those are refractory to some of the medications. And then basically it's also very, very important to not only rely on actual treatments, but management to control kind of these parasites. Okay, so various management practices should be put into place, including removing feces from the environment to ensure that you don't have the eggs that are then kind of going to infect your horses. Okay, so again, goals should be to minimize the risks of disease, to control shedding so that you have less infection, and then to maintain the efficacy of drugs and prevent developing resistance. Okay, so the more and more resistance we develop, the less and less we can rely on drugs. So it's important for you guys to kind of do things that protect this for all of us. Okay. Okay, so when speaking about deworming the adult horse, the main consideration is going to be control of cyathostomes, because they're the more difficult worm to diagnose and to treat. Okay, so depending on the climatic conditions, so wet, hot conditions being more likely to have higher worm burdens, you're going to do 1 to 2 yearly treatments with an effective larvicidal kind of compound. So remember, either moxidectin or 5 days of fenbendazole. And that should then kind of cover those horses in terms of cyathostomes. It will also then in conjunction cover them for large strongulls. Okay. Then it's important to basically think that including specifically this larvicidal or encysted cyatostome agent, when there is a peak burden, you have to be careful of this. Okay, so if you deworm horses when they have large encysted levels of this, you can actually promote disease, because you then have all these little worms dying off in the colon, and that can actually cause the inflammation you're trying to prevent. Okay, so it's important just to note when and which climates that is kind of seen in. And then you want to, as I said earlier, include at least once annually treatments against the cestodes, so tapeworms. Okay. So in essence, these cases, you're going to have 1 to 2 dewormings a year that are kind of obligatory. And then any additional deworming is going to basically be related to fecal egg counts. Okay. So another important thing to consider is to evaluate the efficacy of your dewormers, so at least every 3 years. How do we evaluate the efficacy? Well, we're going to perform fecal egg count reduction tests, which we'll discuss in a little bit. And then, as I said to you, above and beyond the once to twice yearly deworming we discussed earlier, you want to try and categorize your horses. So you're going to perform these McMaster fecal egg counts and group the horses into groups of either low shedders, so less than 200 eggs per gram of feces, or moderate to high shedders, which are obviously greater than 200 eggs per gram. The low shedders are only going to have that obligatory deworming, so the once to twice yearly. The horses in the moderate to high shedders group are going to basically be dewormed to try and prevent this high shedding into the environment. So you may do these tests on those groups, the fecal egg counts, more frequently, and then deworm them as long as they remain in this group specifically. Okay, so multiple dewormings maybe for these cases. Okay, just a quick kind of overview again of the fecal egg count. So I'm sure everyone remembers how it's done. So why are we doing it? Well, one of the reasons obviously is to check the efficacy of your anthelmintics. You're going to evaluate and monitor the egg reappearance period. You can determine the shedding status of the horses, and you can determine in foals whether the burden of worms is mostly parascarus or strong-lid type, and obviously that's going to influence on which dewormer we use. Remember, we don't want to use the paralytic dewormer, the macrocyclic lactones, if they have high parascarus worm burdens. Okay. The limitations, remember that it doesn't accurately reflect the total number of worms. Okay, so you can have horses that are got high worm burdens that are not necessarily shedding worms, because a lot of those worms may be within the pre-patent period, so not actually producing eggs. It doesn't detect immature or larval stages, so it only detects adults, and as we said, those are kind of the stages that we're concerned about causing disease in a lot of horses. Tapeworm infections you often miss because they don't shed, they shed only intermittently. And then basically you can see this issue with pinworms, although we're not going to focus a huge amount on pinworm, as I said, because it's not a major disease cause. Okay, so remember, you take basically 4 grams of feces to do these tests. In essence, as we said, adult horses with fecal egg counts, specifically to stronglids, greater than 200 eggs per gram are going to be considered in the treatment group. We do slightly adjust this in horses that are juvenile or geriatric to 100 eggs per gram. Because these horses are more prone to actually developing disease. Okay, so just a kind of a table that covers that for you. Okay, what is important for me to mention to you guys is that the figures that they claim in the kind of worm literature is that 80% of the eggs that you see in the environment are basically shed by only 20% of the actual horses in that environment. Okay, so this basically tells you that there are some horses, a portion of the horse population, that are going to be responsible for the majority of like the infectious nature of worms, and it's those 20% that you're going to really be focusing on with these deworming strategies. Okay. Then I said we'd discuss fecal egg count reduction tests. So basically what you're going to do is you pick 5 to 10 horses on a property. You obviously do pre-treatment egg counts. And because we said we focus on these moderate to high worm groups, it's going to be preferably horses that have 200 eggs per gram. And then you're going to have accurate dosing for your dewormer, so you're dosing at 110% of estimated body weight, and then you repeat the fecal egg counts on these horses after 14 days, and depending on how much it has dropped, you can see the tables kind of give you an idea. You can tell how bad the resistance is in those kind of specific drug classes. Okay, so these are the 3 drug classes that are really important for you guys to know. Okay, and that's why I put this table there for you guys. And then this is telling you basically in general what the current scenario is. Okay, so basically in cyclostomes there's widespread resistance in general to benzimidazoles, and you can see like for cyclostomes it's not looking that great. Widespread, common, early indications. So and we only really have that is currently effective. So that's why we say we need to be careful of this resistance. Okay. Considerations for weanlings or foals. Okay, so you are not going to be following this same fecal egg count targeting in foals as you do in adults. You're going to generally follow a more kind of set protocol. So during the first year of life, the foal should receive a minimum of 4 anthelmintic treatments. The first is going to be at 2 to 3 months, and you're normally going to use a benzimidazole. So fenbendazole most commonly, because that's most likely when you're going to have aspirates. Okay. The second deworming is going to happen just before weaning, so approximately 4 to 6 months of age. At weaning, you're then going to look at performing a fecal egg count to determine whether the worm burdens are still predominantly aspirates or if they're moved over to strongulates, and then basically decide on your deworming class based on that. So you still have lots of aspirates, you stick to the benzimidazoles, you have very little aspirates, you can now consider something that is maybe more effective and doesn't have the risks of paralysis. So maybe you're going to go to one of the macrocyclic lactones. Okay. And then your 3rd and 4th treatments are going to be considered at 9 and 12 months respectively, just as an approximation. And at this stage, you're generally going to target the strong dials. Hopefully by that stage, you develop some degree of immunity to the aspirates. But remember, if you have very high worm burdens for aspirates at this weaning period, it's maybe not the worst idea in these periods also just to confirm that there has been a change in the worm profiles with your fecal egg counts. Okay, so it doesn't hurt to do fecal egg counts in these cases. And then obviously you're going to include a treatment against tapeworm generally at the 9-month treatment mark. Okay, so that's a fairly good protocol for applying in young horses. Okay. Then young horses, you want to perform this fecal egg count reduction test yearly to evaluate the efficacies against these 2 worm classes, so strongyles and aspirates. And then remember some management things. Recently, weaned foals shouldn't be turned out onto the cleanest pastures. And yearlings and 2-year-olds should continue to be treated as high shedders and receive at least 3 yearly treatments with an efficacious drug. Okay. If you guys want to go and look at this like deworming regulations in more detail, that's a link for you guys to go. So this AAEP parasite control guidelines are pretty important for you guys to look through. I recommend you do that. And this is basically just a summary of kind of what we've already discussed. It basically comes directly out of those guidelines. Okay. Good. Questions on deworming? Yes. Right, okay, my apologies. So, sorry, I said that they shouldn't. So, recently weaned foals should be turned out onto the cleanest pastures with the lowest parasite burdens. Why do you guys think that is? this is one of those, a good example of, if I had thought logically about what I was saying, then I wouldn't have made the mistake that I made. Okay, so if you guys know something about horses, or any animals, I guess, weaning, what is associated with weaning? Stress. Okay, so you want to have these foals that are stressed, exposed to high worm burdens? No, because it's going to be more likely that they develop infections. Okay, so hence why wean foals rather on clean pastures, and quite, as you said, I was incorrect previously to say that. Okay, so the slides are correct, don't follow that. Okay, good. Other questions? Okay, good. Everyone's deworming is on par. Okay, I expect 100% of that section in the exams. Okay, are you guys happy to continue for a bit, or do you want to take another short break? Okay, break. Okay. What time does your periods end? Like 1 o'clock. Okay, so can we take a very short break? Like, again, please be back in 5 minutes. I don't want to run out of time and not cover everything. So fluid therapy, I think there will be some slides that I'm not going to spend a huge amount of time on. But basically, we obviously want to cover some basics on this. So the first is basically the hydration status of your patient. Why is this important? Well, this is going to directly guide you in terms of what the fluid needs of your patient are. Okay. I think the exact kind of causes or indicators of this dehydration I'm going to leave for you to go through. Okay, it's fairly well explained in the table, but looking at things like heart rate, mucous membranes, capillary refill time, skin turgor, and then packed cell volume and total protein are things you guys should remember, kind of be ringing a bell in your head. Okay. So the percentage dehydration, which you guys can estimate based on these tables, is important because this is what's going to tell you a little bit about what the fluid deficit in your patient at that time is. Okay. Then another important, just kind of general discussion is the difference between dehydration and hypervolemia. Okay, so basically hypervolemia can be a severe form of dehydration, but not all dehydrated patients are specifically hypervolemic. Okay, so dehydration is a chronic thing, normally happens over several days. It's a decrease in the total body water with failure to replace that water. You're going to see increased skin tenting, dry mucous membranes, and in severe cases you can have muscle cramping and tachycardia. Hypervolemia is something that you're going to be discussing in hours, because remember, this has consequences that the horse is going to imminently die, where this maybe only has consequences of it going to die over a period of time as it progresses to this. Okay. So in essence, what it is loss of specifically your vascular volume, not your total body water. Horses are generally very debilitated with this, and they present with shock state. Okay, so you have poor tissue perfusion, tachycardia is like a cardinal sign, and then hemoconcentration, so really high packed cell volume hematocrit values seen in those cases. Okay. And then I just remind you guys of the differences in what total body water is comprised of. So you obviously have intracellular and extracellular fluid, and then you have intravascular and interstitial fluid in your extracellular fluid compartments. Okay, good. Concept I just briefly bring your attention to is the idea of lactate. So this is another kind of aspect you can use to measure the hydration status of your patients. There's various reasons that it's produced. So it's a waste product, a metabolic product, and it's produced when you have anaerobic metabolism, when you have poor tissue oxygenation during exercise, and normally it's going to be less than 2 millimoles per liter. Okay, so for any body fluids, lactate should be less than 2 millimoles per liter. And then common causes of having this pathologically increased is obviously hypovolemia, dehydration, endotoxemia, ischemic intestines, and then in some cases of myopathy. But in exercise, you may see it go up really substantially. So like in racehorses that are competing at like full out capacities, you can have really high lactates, but these should drop off to normal once those animals go into a rest period. Okay, good. Then we speak about how we kind of correct these problems, the types of fluids we're going to look at. Okay, so the basic classification between the two is going to be crystalloids and colloids. Okay, so crystalloids are solutions made up of water, sodium or glucose, and other electrolytes, and generally a buffer. You can get hypertonic, isotonic, or hypertonic solutions, and that's relative to plasma. So they generally have quick redistribution between the intravascular and interstitial compartments. Okay, so they don't necessarily sit for long periods in the bloodstream if you have dehydrated individuals. Okay, and then obviously we have colloids, which we're going to divide into synthetic and natural colloids. They contain large sugar or protein molecules, and these struggle to leave the vascular space. Okay, so they serve to hopefully increase your colloidal oncotic pressures and kind of retain that oncotic pool in the blood vessels. Okay, so basically the positive of these drugs is that they have these large molecules, they increase oncotic pressure, they provide rapid intravascular volume replacement by expanding the plasma volume with this oncotic pool. Okay, this volume replacement is going to improve your microvascular perfusion, and it's going to reduce tissue edema formation. But there are some cons about these agents. So obviously they are affected by alterations in capillary permeability. So if you have damage specifically to the vessels and you have increased kind of intravascular space, then you may have leakage of these. They don't correct dehydration. Okay, so if you're giving colloids, you generally have to follow up with crystalloids to prevent kind of worsening of dehydration. And then they do have some side effects, so mostly looked at in people, but coagulopathies and some renal kind of side effects are important to consider. So they're not kind of completely benign. The other thing that's important to note is, sorry, just for this is that the natural colloids don't have the same kind of efficacy in regards to this as the synthetic colloids do. Okay, so the synthetic colloids are the ones that you're going to generally have providing this rapid expansion of the vascular volume, and the natural colloids don't have that same kind of pro towards that, although they do still help with the oncotic pressure to some extent. Okay, basically I think this is one of the slides I'm not going to spend a huge amount of time on. It's basically looking at the differences between isotonic, hypotonic and hypertonic crystalloids. The main ones we're going to be focusing on is the isotonic. So basically the same as plasma. They often are low in potassium, and as we said, they generally have a buffer to try and kind of help with acid-base balance. These hypertonic solutions, basically the one we need you to know is hypertonic saline, are again going to be used when you want rapid expansion of the circulating volume. So that's going to be used in those cases. But remember, they do then result in intracellular dehydration. And then hypertonic solutions, I think, are probably not that important for you guys to know at this stage. Okay. Good. I think this table basically just gives you some examples of the common fluids you're going to see used. So 0.9% or isotonic sodium chloride, plasma beta-Regis lactate, and you guys can just have a look through and see what the general components of that are. Okay. Then I think it's also important to just have a general concept of maintenance versus resuscitation fluids. Okay, so replacement or resuscitation fluids are going to be fluids that replace lost fluids and electrolytes. So they're preferably only used for short term, or if you have specific electrolyte derangements. And they're usually high in sodium but low in potassium, which is slightly different to the normal kind of plasma kind of components. And in some cases you may have to add potassium to these fluids if you're going to use them in longer term to prevent hyperkalemia. This is for horses, please. I don't know in other species. Okay. Then obviously you have maintenance fluids, and this is fluids that you want to have to maintain a normal fluid values. Okay. So long-term fluid therapies, and as I said, these are generally higher in potassium, and these are fluids that you're going to hopefully have horses on that need fluids for long periods. So within the first 24 hours, and then hopefully moving over to maintenance fluids. Although strangely enough, we don't seem to stock maintenance fluids that regularly, hence why I mentioned this idea of adding some potassium to these replacement fluids. I think the equine ability to manage acid, base, and electrolyte derangements is quite good. So this is maybe slightly less applicable in adult horses than it is in small animals. And certainly this is very applicable to foals, okay? So important to remember when we're dealing with foals, okay? Good. Then colloids, as I said, we have these two different kinds. So obviously we have natural colloids, so that's going to be plasma and whole blood. And then we have synthetic colloids that generally have some form of large starch molecule. A good example of this is going to be Voluven. So plasma, the main agent we're looking at is albumin. So that's the primary component, and it contributes the 65 to 75% of plasma colloidal oncotic pressure. And it's normally used in cases where you want additional benefits. Okay, so plasma also has immunoglobulins, it has clotting factors and anticoagulants. So in horses that need those components as well as maybe increased oncotic pressure, you're going to look at giving some colloids. Whole blood, I mean, basically, as you would expect, you're going to give it when you have either acute severe hemorrhage or hemolysis. Just a note on the donor. So donors should be preferably equine blood type AA and QA antibody and antigen negative, because those are the most common blood types that you're going to have cross-reaction between donor and recipient. Okay, and then obviously these, which we said are going to be the ones that help with rapid volume expansion, but obviously have these side effects that we mentioned earlier with this specific dose-dependent effect on coagulation. So they reduce the coagulability of the blood. Okay, and then we have a maximum kind of administration of approximately 10 mL per kg for these synthetic colloids. Covering electrolytes fairly rapidly. Okay, so ideally you want to measure electrolytes after you've corrected your fluid deficit. So you'll measure these, and you may have abnormalities when the animal is dehydrated. But in giving the horse fluids, you support the kidney's function of actually changing these electrolytes. So to get a true idea of these values, you're mostly going to rely on once the horse is rehydrated. And then you can start kind of looking at doing specific supplementations of that. The most common abnormalities for horses, the first one being hypokalemia. So it's generally caused because of fasting or giving low potassium fluids. And you can obviously supplement it. Important to remember this value, okay? So 0.5 milliequivalents per kg per hour. That is the maximum safe rate that you can supplement potassium at, okay? If you give it faster than that, you're going to kill the horse. If you give it slower than that, obviously it's regarded as safe. So important, NB times a million, okay? If you actually work this out in horses, it's quite a large value, but still something to be aware of. Then hypocalcemia, also fairly common in horses that are not eating or have colic. You generally can correct this by giving, you get variable percentages, but commonly 23% calcium gluconate at approximately 20 to 60 mils per liter. And then you recheck this after 4 to 6 hours to see if you need to continue supplementing. And then hypomagnesemia, obviously also common in the colic patients, and you're going to supplement these horses with magnesium sulfate. These are all three cases, things that can cause ileus. Okay, so, or at least contribute to ileus. So hypokalemia, hypocalcemia, hypomagnesemia are going to be predisposing horses to ileus. Remember this for when you guys do your GRT lectures later in the year. Okay. Okay. Acid-base balance, I think, is at this stage of your guys' career more of something for interest's sake, then it's really important for you guys to know. Yes.
So what is ileus?
Ileus, okay, so that's basically where you don't have intestinal contraction. Okay, so the intestine is basically just sitting there not doing anything. Okay, so I'm going to skip over this page. I don't think it's of a huge importance for you currently. Okay, so the aims of our fluid therapy is basically to establish and maintain end organ perfusion so that you ensure those organs are oxygenated. Okay, so that's one of the main functions of blood, and that's going to be the acute kind of idea that you need to use. The most common routes are going to be enteral and IV administration, although you can get per rectum, for instance, administration of fluids that can lead to improvements in hydration status and that. Okay, so enteral fluids quickly, basically generally have a much lower cost. Why? Because they don't have to be sterile. They should be clean, but not sterile. The GRT mucosa acts as a natural selective barrier, and it's less likely that you cause iatrogenic imbalances with enteral fluids than with IV fluids. And surprisingly, absorption through this route is relatively quick, so within 30 minutes. So those are basically the indications. I think the ones that I highlight to you guys is that you may want this additionally to hydrate the GRT contents. So also important if you have impaction of contents in the lumen. And it can also help stimulate intestinal motility via something we call the gastrocolic reflex. Okay, so the tension on the stomach leads to contraction of the colon. That's the reflex. Okay, generally administered via nasogastric or nasoesophageal tube, and ideally you want these fluids to be isotonic, so that they don't cause or less likely to cause these electrolyte fluctuations. Okay. So I don't know how many of you guys have seen us tubing, but basically this is placing a nasogastric tube. I mean, it's basically like a hose pipe sized tube. You insert it mostly through the horse's nose into the stomach, and obviously can give fluids in that fashion. Okay, just so you guys are generally aware. Okay, then IV administration. So how do we administer it? Well, it's via IV catheters. I think you get various different kinds. I'm going to kind of move on. I think it's important to consider the idea that different catheters have different kind of properties. So when considering this, you must take into account how quickly you want the fluids to flow. So the rate of flow is going to be related to the diameter of the catheter, the length of the catheter, and then the viscosity of the fluid. So the greater the diameter, the more quickly fluids will flow. The longer the catheter, the slower fluids will flow. The more viscous the fluid, the slower fluids will flow. Okay. So basically that is something to consider. And then obviously you want to consider things that are like size of the animal. You can't put a catheter that is this long into a vein that is only this long. Okay. And then I think another important one of these is for resuscitation, you're going to use 6 to 20 mils per kg of fluids, so approximately 10 liters in a 500 kg horse. You're then going to reassess and you're going to repeat as necessary in these resuscitation cases. Okay. Don't be confused with this. This isn't the maintenance requirements for a horse. Okay, we'll cover that in a second. This is what you would do in a resuscitation scenario. Okay, the type of catheters, or what it's made out of, is generally going to tell you how thrombogenic it is, so how likely it is to produce clotting. And you can see on this basically that some of them are more and less thrombogenic. Just important to note that we do not use these polypropylene catheters because they are so thrombogenic in horses. Okay. Okay, placing IV catheter, basically a good example, it's going to be in the top third of the vein. You're going to clip an aseptically prep, place 1 to 2 mils of local anesthetic under the skin, because these are big catheters, they're normally 12 or 14 gauge, so you do that just for comfort of the animal. Okay, sterile, very important, so we use sterile gloves in most cases. And then you can do a small stab incision if you have thick skin or soft catheter material, but you don't have to specifically do that. Okay, so there's one of these 14 gauge catheters. They're approximately 20 centimeters long, going into the jugular vein of a horse, and then basically what it looks like when it is secured. Okay. Good, just another kind of a little resource for you guys, just for your interest's sake. Over the wire catheters, something that we're going to place in falls. So the previous catheters you will have seen are over the needle. So you have a stylet inside the catheter. In these cases, you place a wire in the vein and then you thread this catheter and guide it into the vein over a wire. Okay. Just for interest's sake, you guys will see this more when you come on to clinics. Okay, important, this catheter is the least thrombogenic. Okay, so basically this is why we will use it in certain scenarios. Okay, so why do we care about how thrombogenic they are? Well, most horses get these catheters in their jugular veins, okay, and that's basically a central vein, quite an important vein. And you can see these are cases of thrombophlebitis, so clotting and occlusion of the vein. You can see the distended vein, you can see the distended vasculature. This horse is a horse that has bilateral occlusion of the jugular veins, which they generally develop head swelling. Okay, so important to try and prevent this as much as possible. Okay, types of catheters, don't stress too much. I think proper handling is something that you guys can go over on your own. Sites, we said jugular vein is generally first choice. Alternatives, lateral thoracic or cephalic. And in some cases like falls, you can do saphenous veins. But these other areas generally require more frequent flushing, and they are easy to dislodge because those are places of high motion. Okay. So this is basically just some other examples. So lateral thoracic vein, cephalic vein, obviously you guys know of the jugular. Okay, that's just a picture of a catheter in the lateral thoracic vein. Good, okay, and then I think you guys can go over this on your own. I don't think it's specifically something that is difficult for me to cover. I know we're close to ending. If we can just try and finish this a little bit, please. Okay, so this is important. Volumes of fluids to administer. Okay, so remember that the volume of fluids that the animal requires is the maintenance requirement plus the amount you need to correct dehydration and the amount that is going to cover ongoing losses. Okay, so important values to remember. Adult horses, the maintenance rate of fluids is 40 to 60 mils per kg per day. I don't really care which of the ones you pick, but between 40 and 60. In foals, what is important is basically that you know that it's 100 mils per kg per day. There is this mention of this dry foal formula for sick foals. It is something that we often apply, but this is the one I want you guys to remember. Okay, 100 mils per kg per day for foals as maintenance. Okay. Remember, ongoing losses, what the horse is losing through things like nasogastric reflux, diarrhea, those kind of things. In general, you probably have to estimate these losses. Okay, so you would have to estimate that the horse is losing X number of liters per hour in these additional things. This doesn't necessarily include urination and these common physiological functions. Okay. So the hypovolemic adult horse, we kind of mentioned this a little bit, but basically you're going to have to give this bolus of fluids to resuscitate. Then you're going to reevaluate the patient's hydration status. Remember that you have the standard maintenance dose, and then you have to factor in ongoing losses, and then you want to plan to resolve dehydration generally over the first 24 hours. Okay. And then I just kind of give you guys one of these calculations. So you guys need to know how to do these fluid calculations. Okay, very important. Okay, so an example is you have a 500 kilo horse that's 2% dehydrated and has 1 liter per hour estimated losses. And basically what you probably be asked to do is what is the horse's fluid requirements in 24 hours, for instance, which is what you see here. So the step one is you work on how much do you need to correct dehydration. So basically you're going to multiply the 2% into the weight and you're going to get the amount there. So if you're going to say percentage, then you're going to multiply 2 by 500 by 10 to get it to liters. If you're going to do it in this route, then you're going to say 0.02, sorry, that would be probably to milliliters. But if you do it like this, it's going to give you directly to liters. Okay, so 0.02, which is the percent multiplied by weight, 10 liters to correct dehydration. Then step 2, what is the maintenance for this horse? 500 kilos multiplied by maintenance rate gives you 30 liters. And then the easy part of the calculation, which I gave you, was 1 liter per hour. So 1 liter gives you 24 liters in 24 hours. Okay. So how much does this horse require in 24 hours? The percentage dehydration plus maintenance plus losses. Okay. Does it make sense to you guys? Okay. Remember it, go through it, it's something that is important. Okay. And then there's obviously just some conversions, basically, if you want to go to milliliters. So 64 liters in 24 hours is 64,000 milliliters. That works out if you divide it to 2,666 mils or 2.6 liters per hour, which is the supplement rate that you're normally going to work at in terms of your calculations. Okay. But the page before this is important. If you can get to the total amount in 24 hours, then this is basic arithmetic. Okay. Basically, that covers everything. Okay. Good. If you have other questions, you can